All right, so getting into the second part of pulmonology here, we're going to start talking about asthma. So again, it's a big deal because you're going to see a lot of patients that have to deal with this. What's kind of the issue with asthma? What's the main kind of pathophysiologic issue that's happening here? Hypersensitivity causing bronchoconstriction, right? Absolutely. So again, bronchoconstriction is the big issue here, and so we're going to be looking at what can cause that bronchoconstriction. Allergies, food potentially, medications, chemicals, cold air. I mean, like anything can trigger off some of these really sensitive patients and cause some bronchoconstriction here, right? So the airway can be a little sensitive in some of those, right? So the main thing, you're seeing a lot of coughing, wheezing, shortness of breath, right? So you're gonna see a lot of patients coming into the urgent care. And now that we're moving into a little bit of the more fall time, I mean, we don't really have winter here, so to speak, but now we're getting more into that fall type period. I'm starting to see a lot of kids in the ER coming in for asthma exacerbations. A lot of albuterol, ipratropium steroids, Like we're getting a lot of those kids coming in now, and you're starting to see that as the seasons change, right? So this is a big deal. That's why we're going to harp on it so much. Anyway, the big role to play here is going to be allergens, right? We're going to see a lot of this is IgE mediated, so along the same lines as what we saw with anaphylaxis, you're going to see a lot of carryover with a lot of the meds we're going to be using here, right? Probably not a whole lot of epinephrine, but a lot of drugs are going to be working along those same pathways, because the main receptor we're going to be talking about hitting here is going to be what? Oh, we'll talk a little bit about H1, but not so much as far as the actual bronchoconstriction aspect goes. Beta2, right? Beta2 is going to be the big thing we're going to be focusing on here, right? And again, when you have these allergens come along, you have a lot of mast cell degranulation. That's going to cause a lot of inflammatory cytokines to be produced. That's when you're going to see things like these increase in the airway resistance, because you're going to have bronchoconstriction occur here. You also have a lot of mucus production that's happening. That's also blocking up the airways and impeding the oxygenation from occurring, okay? So again, a lot of other things involved here, histamine, tryptase, leukotrienes. This is going to be a big role to play with some of the medications we're going to look at. Prostaglandins, all of these are going to be playing a role here. Again, lots of different things can provoke a response, and in fact, in some ways, we actually can diagnose asthma based on trying to provoke a response in patients. There's actually a drug called methylxanthines that actually we try to induce asthma attacks in patients, and if that works, if we have a decrease in things like, have you gotten over your pulmonary function test already? So what's a big thing you would see a decrease in with asthma attacks? FEV1, right? They wouldn't be able to expel a lot of air there. FEV1 decreases would show us, hey, this patient has a really hyper-responsive airway, and then you give them a reversal agent for that. But again, that's a big thing we're going to be looking for here. So the main therapeutic approaches we're going to be focusing on with asthma is that, one, we would like to reverse the bronchospasm. You can see some of the drugs you're going to be using here for that. We'd like to remove the trigger or whatever's causing, say, for instance, the mast cells to degranulate. So we'll have a couple drugs that work through that pathway. And then the other big thing we're going to do is try to control that inflammation, okay? The big thing to note with asthma medications is we're going to have what we call rescue medications or quick-acting medications, and then you have controller medications, okay? Controller medications have to be on all the time in order for them to work and for them to be consistent. The rescue medications are going to be used as an as-needed basis. Okay, and I think did I put an albuterol prescription on your assignment? I think I did, yeah. So that would be one that you can look at that. And so you're going to see that's a rescue medication. That's something they're not going to use scheduled, Sometimes for acute exacerbations or being admitted, they'll be on a schedule, but for the most part, this is going to be a rescue medication on the outpatient basis. Uh-huh. So it depends on what you're using, right? So again, if you're, say, for instance, giving them a prescription for a nebulizer, then you may give them an actual volume that you're going to be dosing it as, and then you'd have to say how many of those little respicules you'd have to give them, right? The nebulizer vials. If you're giving an inhaler, you have to specify the size of the inhaler you're going to be giving them, right? So again, looking at those dosage form sections in Lexicomp or something will kind of give you a clue as to what you should be dosing it as, right? Anyway, so those are the big things. Now, as far as symptomatology goes, obviously you're going to be categorizing them. I'm not going to get really into the diagnosis aspect or the classification, but just know a lot of this in your decision on which medications to use is dictated based on symptomatology, right? So again, if they only have, say, exercise-induced asthma and it's very predictable when it's going to occur, they probably don't need a lot of controller medications to control that. They may just need a rescue inhaler right before they go and exercise, right? If it's something where it's going to be chronic and they're waking up several times a night, they're having to use a rescue inhaler all the time, they're going to need something that's going to be able to help control them throughout the 24-hour period. And I'll tell you what, my mom was a nurse, but when I was growing up, I had pretty bad asthma. I was on no controller medications. I had to have my rescue inhaler with me all the time. I was a very poorly controlled asthmatic patient, right? And again, even if you have healthcare providers in the house, doesn't mean you're going to manage all that well. But it's one of the things that as soon as you get a controller medication on board, all of a sudden I didn't have to carry my inhaler with me. It was great. It's one less thing I had to have in my pockets at all times. So just know that looking at the patient, looking at symptomatology will help decide how you're going to manage that patient. So we'll give you all the options we have. So again, the things we're going to do is focus on trying to decrease that airway hyperresponsiveness, decrease that inflammation. We're going to have things like reducing that inflammation by using things like corticosteroids. You're going to find that a lot of the intranasal corticosteroids, what's kind of a unique side effect with those? Epistaxis, right? Because again, that's directly applied to the nasal mucosa, right? Versus here we're going to be seeing inhaled corticosteroids, right? All the same drugs basically are going to be represented here. You're still going to see the fluticasone, the mometasone, the budesonide. All of those things are going to pop up here as well. But again, make sure you're going to be specifying, like on your prescriptions and whatnot, that it's the inhaled form and not the intranasal form, because that's a big medication area that you see somewhat commonly. Maybe not critical from a patient harm standpoint, but it's a very frequent thing where a patient goes home and all of a sudden they thought they were getting an inhaler and they have a nasal spray and they're like, what the heck is this? So they try to put the nasal spray in their mouth and it just doesn't work out, right? But it happens. It sounds silly, but these kind of medication errors that sound like they should be no-brainers can be somewhat problematic just because humans are fallible, right? And then one of the big things we're going to focus on is the preventing or reversing the acute bronchospasm. This is where we can have things like avoiding the allergens whenever possible, obviously, but we're going to be treating this short term with beta-2 agonists. That's going to be the cornerstone of that kind of quick rescue sort of therapy is a beta-2 agonist. So looking at this, the quick relief medications include our short-acting beta-2 agonist. Albuterol is going to be the big one here we're going to see in just a moment. We're going to have some anticholinergics. Now, if you think about cholinergics, what do we say was the mnemonic that we use for the muscarinic actions? We use the dumbbells, right? So again, remember the dumbbells was like diarrhea, urination, meiosis, all that. Remember what was the B's? Bronchorrhea, bronchospasm, bradycardia. So again, looking at the lungs from that standpoint, that's what we're seeing is that the cholinergic aspects of this, of the parasympathetic nervous system, is going to cause that bronchoconstriction, going to cause that mucus production. So one of the things we can do is use an anticholinergic to try to dry out that airway and try to cause it, try to decrease that airway responsiveness. Okay, so we're going to see that's going to be another quick-acting medication we can use in a little bit, and then systemic corticosteroids are going to be really good here as well, right? Not inhaled corticosteroids, but systemic corticosteroids are going to be better for an acute exacerbation. Okay. Long-term medications, we're going to have long-acting beta agonists, we're going to have inhaled corticosteroids, and we're going to have a whole litany of other drugs, which we'll talk about here in more detail, kind of going in potent and going from kind of the most potent agents, kind of the best acting ones, to the ones you're going to use less and less frequently because either they have some side effects associated with them or maybe they're not quite as effective. All right, so beta-2 agonists, how are they going to be working? It's called bronchodilation by agonizing the beta-2 receptors. Good, right? So again, this is why when we get into things like cardiology, when we start talking about beta blockers, it's going to be important when you're talking about what kind of beta blocker do you want to use for a patient with asthma, because you don't want to be blocking up these beta-2 receptors. Okay, that'll be important a little bit later. But the big thing here is it's going to activate beta-2 receptors. It's going to cause smooth muscle relaxation, and it works pretty quick for the most part, right? So again, works within several seconds to a minute to really kind of get the airway starting to relax a little bit. And usually lasts about 4 to 6 hours or so depending on kind of the degree of inflammation. Now we're going to have some long-acting ones. They're going to be working for the better part of the day, so about 12 hours or so. A lot of those long-acting ones you're going to see they usually have twice daily dosing in order to give you kind of full 24-hour coverage there. Big side effects you're going to see with the beta-2 agonists is one's going to increase heart rate. Now, why does that happen, do you think? What kind of receptors are on the heart mainly? Beta-1, right? So again, remember, these are not 100% selective drugs. If you give a big enough dose, you're going to see some bleed over, not just affect beta-2, but beta-1 as well. So again, the bigger the dose you get, the more likely you are to see tachycardia with that. When you activate beta receptors on the skeletal muscle, you're going to see tremor associated with that. Does anyone know what electrolyte shift you might see with a beta-2 agonist? Potassium, yeah. So actually, when you activate beta-2 receptors, you're going to cause hypokalemia potentially. And again, all of it has to do with the dose, but you're going to cause a shift of potassium into the cell. It's actually a trick you can use if you have a patient with hyperkalemia that you don't have IV access on yet. You can start to give them albuterol, and that will help to kind of get that potassium down a little bit. It's not super potent, but it can do a little bit of good there until you get more definitive access. But again, the dose is all going to be really important here. So I'll talk about actually how we're going to be using these medications, because again, technique is super important for delivery of these medications, these inhaled medications, as we'll see here in a second. But the two big short-acting agents we have, albuterol. That's the gold standard. We've been using that for decades now. Several brand names, ProAir, Ventolin. There's a PO form of albuterol. We don't like to use that really ever. I see very few patients on that, mainly because the side effects tend to be so severe. Again, when you're using inhaled drugs, you tend to get less systemic side effects, which is nice. Okay, but again, we'll see that's going to be dose dependent here in just a minute. The other one we have called levoalbuterol or Xopenex. Now, looking at that, what do you think the relationship is between those two? Yeah, so again, levoalbuterol is going to be one of the enantiomers of the racemic mixture of albuterol, right? So you just take the left-handed version out of it. Some patients, they say they get fewer side effects out of it. Honestly, a lot of it has to do with the dose that they're being administered. So some patients are going to absolutely say, I got to have my Xopenex. A lot of places like, no, we'll just give you a smaller dose of albuterol and it works out just fine. But some people are really, really sold on that Xopenex, and so it's expensive though. So hospitals don't like to carry it. So we're like, we can bring in your own Xopenex. That's fine. We'll let you do that. Now, long-acting medications, these you do not want to use by themselves. This is actually something that you'll see used by themselves for COPD potentially, but you do not want to use these by themselves for asthma, because they've actually found increased mortality in these asthmatic patients. You don't want to use these by themselves. But the two we have are going to be formoterol and salmeterol. And in fact, most of the time you're going to find these two mixed in with an inhaled corticosteroid. So if anyone's ever heard like Advair or Symbicort, things like that, those are typically going to be a steroid mixed with a long-acting beta agonist. Okay, so we'll talk about that rationale in just a few minutes here. And again, if you're having an acute asthma attack, which one of these would be appropriate? Albuterol, levoalbuterol. Both of those would be totally fine. You do not want to use a long-acting drug for an acute asthma exacerbation. They won't kick in fast enough. You're not really going to get much effect out of that. Okay, it's a very important point to know there. So we mentioned tachycardia. Maybe hypotension a little bit in very high doses, but the biggest thing are going to be some of the CNS side effects. They're going to get a little jumpy. They're going to have some tremor. You may have a little bit of dizziness. Those are the big things. You may see a little bit of hyperglycemia associated with that, because you're activating beta receptors on the liver, so that causes glycogenolysis and gluconeogenesis. But hypokalemia can be the other big thing you see that. And again, we can sometimes use that to our benefit if the patient's hyperkalemic and try to shift that into the cells. Again, it's just a temporary thing. It's not like they're losing potassium. They're just moving it around back into the cells, basically. Okay. Now, the other big ones we're going to use, and again, I'll talk about kind of how we're going to manage patients in the end, which kind of want to get to the drugs themselves first. Looking at the corticosteroids, most of these look very familiar because we saw them with the intranasal corticosteroids. You have things like, fluticasone, which is a common one we use. Remember what the brand name was for the intranasal form? Flonase. Now we have Flovent is going to be the inhaled form, right? So again, easy to mix those up because they have the flow on the front of it. Flovent, Flonase, whatever, just give them one of them, right? No, it's not accurate. You got to make sure you give them the right kind in there. So again, any of these are going to work just fine. But the big thing with these to know is how fast do you think they kick in? Very fast, a little slow? Yeah, just like with the nose, like you had to give them a couple weeks before you really see full effect with these drugs. Same thing applies here, right? Now we'll see that if you give systemic steroids, they kick in a little faster. But with the inhaled forms, you got to use them consistently. You got to use them for a few weeks before you really see the full effects with that. I don't know that there's been any head-to-head study. At least I'm not aware of any that compare them. Honestly, they're kind of interchangeable. And the other big thing is you're going to be titrating the dose based on how they're responding, right? So you'll typically find they come as a fixed dose, as a few different ones. For instance, like fluticasone, I know it comes as like a 110 micrograms per dose. If it's not working, then you go up to a 220 or something, right? So you're titrating it based on their response there. But you got to give them a few weeks before you can really titrate and see how they're doing with it. Just 1 or 2 doses is not enough to really see efficacy, because they have to have time to get in there and really kind of soak in and change all those transcription factors and decrease that inflammation, okay? Now, these you could use by themselves for controller medication in asthma, but the long-acting beta agonists you do not want to use by themselves for asthma. Okay, it's kind of the big distinction here. So you may see some patients who maybe have kind of recurrent symptoms, but not necessarily very severe asthma. You may start them on a low-dose inhaled corticosteroid by itself, and then if that's still not working, then maybe you'll add on, say, a long-acting beta agonist. That's where you get one of those combo meds. You have a question first?
Yes. So how long do we have to wait to find out if it's working? If we have to step up the therapy, or do we keep the same? Like, do we have to wait certain weeks?
I'd probably give it at least 2 weeks. If you're really not seeing any change by then I probably want to go ahead and bump it up. But if it's, it's like, okay, it seems moderately effective, maybe give them a few extra weeks. So maybe give them, say 4 to 6 before you really kind of make a decision on changing that. The big benefit here is there's not a ton of side effects associated with these, okay? But we'll talk about one major one that you want to note. here in just a second. But again, in some cases, may be up to 8 weeks before you really see full maximal effect. Usually by 2 to 3, you should start to see some change though, right? And again, the other benefit is if you can give a long-acting beta agonist with that and then combination, the nice thing is the long-acting is going to kind of start working sooner. So you see some benefit there, and then the corticosteroids can kind of kick in, okay? But if they don't take it consistently, it's not going to work. So they take it for a few weeks, they feel better, and they stop taking it, symptoms are going to come right back, right? So again, they need to take it consistently. It's a big thing. Because again, they'll do it where they'll be like, oh, I feel much better. I'm not having to use my rescue inhaler all the time. And then they stop taking it. And all of a sudden they come back and then they got to start it over again, okay? Now the big adverse effect you're going to see with these, because you're inhaling them. Now when you inhale a drug, does all of it make it into the lungs? No, actually fairly, depending on technique, you may find it's pretty variable as far as how much is going to get in there. So where do you think that drug goes? Back to the throat? Where else can it go? Into the GI tract, right? Sometimes you're going to breathe it right back out depending on technique. So one of the big things you see with the corticosteroids, what does it do to your ability to fight infection? Decreases it, right? So oral thrush is one of the big things. So you have to tell patients to make sure they wash their mouth out after they use these drugs, right? Even if it's just rinsing it with water, that's totally fine. Just make sure they do it, because when you get that drug off the back of the throat, otherwise you won't be able to fight off all those little nice candida particles you're probably all breathing in right now, right? Normally you have a good immune system can fight that off, but these will stop that. So normally if you see thrush in a patient, normally thinking, okay, either they're on an inhaled corticosteroid or they may have something else that's probably immunosuppressive. So you see this a lot like in HIV patients or those with immunocompromisation, okay? Anyway, there is some concern about suppressing growth in children, but that's really what's seen with more high doses, just showing that they get a little bit, there is still some systemic absorption here, but not really much as far as systemic side effects you're going to see as compared to the systemic corticosteroids we're going to see in just a few minutes here, okay? Just to show you a few of the combinations you can see here. So things like formoterol and budesonide being the steroid, formoterol being the beta-2 agonist there, the long-acting beta agonist. Again, they'll probably find other ones that will get put out there. These are very effective medications. They're very good for helping to control asthma symptoms for the long term, right? Again, not good for acute asthma exacerbations, but they're good as controller medications, okay? So moving on from that, so those are probably the most potent agents you can have as far as controllers go. Moving on to some other agents, and some of the benefits of these are going to be a lot of them are oral, so you can just take a tablet and then you're good to go. Now, if you remember, looking at the arachidonic acid pathway, right? Remember that's how we get a lot of our prostaglandins. How do we get prostaglandins? What's the enzyme that forms those? Right, cyclooxygenase. If you remember, that's one pathway. What was the other pathway? Leukotriene, right? There's an enzyme called lipoxygenase that form leukotrienes, and leukotrienes tend to cause bronchoconstriction as well. So we're going to see that we can have some leukotriene receptor antagonists, and these are going to be good as controller medications as well. Okay. Now there was one called Zafirlukast, which we don't really use anymore, and I'll talk about why in just a moment. But the big one we use very frequently is Montelukast or Singulair. A lot of people have probably heard of that one. Basically, blocking the LTD4 receptor, just it's a leukotriene receptor antagonist. We don't use that for Lukast due to it inhibiting a lot of CYP enzymes. If we can avoid those interactions, that's going to be better off for our patients overall. So we just use Montelukast usually alone, right? Again, very few side effects from the medication, very well tolerated. So if you have a patient who has pretty meager symptoms, they're somewhat persistent, but nothing too severe, maybe start them out on a leukotriene antagonist because of the fact that it has very few side effects associated with it. I see a lot of kids that get put on this first before they kind of graduate up into the corticosteroids. Again, really kind of minor stuff as far as things you're going to see, but this is kind of general to probably any medication you run into. Nausea, vomiting, no big deal, but for the most part, very well tolerated. Some patients do get really tired on this medication, and for whatever reason, I can't predict who's going to be the ones to get that. But some patients just get really sleepy. I have no idea why. It just happens. So other things we could do potentially to try to remove the trigger, remove the antigen, we can have some mast cell stabilizers. And again, just like we saw with the intranasal meds, sometimes what we saw with the eye meds, we don't use these all that too often, but it could be an alternative if patients could not tolerate anything else. So we have things like cromolyn, which we've seen before. We have netocromel. But remember, what's the thing with mast cell stabilizers? You got to give them before the actual event occurs, because once those mast cells destabilize, you can't put the toothpaste back in the tube, so to speak. So you got to make sure you're using it consistently around the clock. Otherwise, it's not going to be all that effective there. Again, these are going to be inhalers you're going to be using, and so they need to be taken pretty consistently. They need to be taken for several weeks before you can really say how effective they're going to be for those patients. And again, I've not really seen anyone being put on these. More often than not, inhaled corticosteroids. Now that some of them are generic and a little bit cheaper, those tend to be the ones that a lot of providers favor. Again, not as far as side effects go, not a ton here. Now again, bad taste in the mouth. Why do you think that occurs? It's an inhaler, right? So they're going to get some on their tongue. In stomach side effects, you're going to see that just because some of that drug is going to get down to the GI tract. So that's kind of understandable. Okay. Now this is a drug we actually will use in select cases. It's a very powerful drug, but we do not use it very frequently because of some of the side effects seen with it. And in fact, we do a lot of this in our pulmonology clinic over at Nemours. This is called OMalley, otherwise known as Xolair. Okay. Yeah, it's a mouthful. Yeah, so it doesn't really roll off the tongue very well. It takes me a long time to practice saying that. Now, looking at that drug, looking at the name, does anything kind of stand out to you? A MAB. What does that mean? Thank you. Monoclonal antibody, right? So this is going to be an antibody we've actually produced, and it actually is an antibody that targets other antibodies. So it's kind of like the antibody hunter, I guess. But basically, it's going to be targeting the IgE, and by binding that up, it's going to be preventing that inflammation that's associated with asthma, right? So again, if you have patients who are really refractory to a lot of other therapies, they can be put on Xolair that will bind up that IgE and prevent them from having those acute exacerbations, right? It's a very powerful drug, but we're going to see there's going to be some limitations to it.
Is that considered like an immunomodulator?
Well,
Like,
I guess. I mean, it's a modulating part of the immune system, so I suppose, yeah, you could call it that. It's not necessarily doing anything with like, neutrophil action or like tumor necrosis factor or things like that. So it's not really dealing with. You couldn't use this for like an autoimmune condition.
it sounds like other autoimmune like medications. That's why I was.
Yeah, so you can. I mean, it's still an antibody targeted against a specific product that we're producing. So just like you could use, something against tumor necrosis factor for rheumatoid arthritis, this is again targeting a specific part of the pathophysiologic disease process. So yeah, I guess you can call it immunomodulator if you like, but you can call it whatever you like. To be honest, like I don't really care.
I'm trying to figure out what like group it's in.
Yeah, so this one's kind of unique in and of itself because of the fact that, again, it's targeting that IgE specifically. So if you don't have IgE there, guess what? Those mast cells never get activated in the first place. So again, very effective. But the other big thing to note here is that whenever you're injecting a monoclonal antibody, you have to worry about infection. Maybe, probably not so much with it because it's dealing with IgE. Certainly with the other drugs we'll talk about, like when you get to like rheum and stuff like that, those are definitely immunomodulators as far as decreasing your ability to fight infection. But the other big thing, it's foreign protein we're injecting, so allergy. Yeah, your body can make a reaction to it, right? So even though it's trying to deal with that IgE that normally causes allergic reactions, it can actually trigger its own allergic reaction, right? Because again, it's a foreign protein. So you have to make sure you're monitoring patients, especially after the first dose. So oftentimes you'll keep them in the clinic for a while, an hour or so, just to see if they're going to have a reaction. And then there are some chances they may sensitize to it later on. So again, it's one of those things you want to make sure to kind of watch them for a little bit. But pretty well tolerated. It's very powerful of a medication. So if they fail everything else, we'll have them put on Xolair. The other problem with it though is because it's a monoclonal antibody. What do you think the cost is? Very expensive, right? A lot of places don't want to pay for it. A lot of insurances don't want to cover it unless you've documented that you failed other things. So you guys ever heard like a prior authorization? What is that?
You have 2-3 doctors you have to approve before you can get it, like, especially for like disability.
Yeah, so basically, in the case of drugs, it's going to be something where like the insurance companies don't want to pay for it for just any Joe Schmo patient. They want to make sure that the patient has kind of gone through everything else, failed other therapies, or that the provider thinks there's a really compelling indication that they need this medication. So a lot of times you'd have to go through some sort of like prior authorization process to say, listen, I failed inhaled corticosteroids, or you're talking on behalf of the patient. They failed this, that. They failed all these medications. I think this is the only appropriate drug for them, and then the insurance company will acquiesce and say, okay, yes, we'll pay for it. Because it is very expensive, they want to make sure that they go through all the hoops before they have to shell out those big bucks for the drug. Okay. There's some concern for secondary malignancies, but again, this is something we may see develop over the course of decades. Who knows at this point if there's anything really definitive. But still in the market, so it can't be that bad, right? Who knows? But again, looking at things like urticaria, anaphylaxis, you can see with this, maybe some injection site pain because it's that monoclonal antibody. Can I give it orally? Nope, it has to be injectable product. So again, this usually gets given sub-Q in the clinic, usually by the nurses there in the pulmonology clinics most often. So this would not be something they would take home and kind of inject themselves usually. Okay. One of the last classes we have here is going to be the methylxanthines. Now, a lot of you may not know, but you're actually all consuming, most of you are consuming a methylxanthine right now. What's in tea? Caffeine. Caffeine's actually a methylxanthine. For a long time, we actually used caffeine as an anti-asthmatic medication because it actually has some good properties to help with bronchoconstriction. So you guys can breathe a little easier, a lot like caffeine coursing through your system, right? Yep. What's another methylxanthine that you can find maybe in chocolate? The specific product in theobromine, right? So again, that's why dogs can't have chocolate, because that theobromine is actually a methylxanthine and causes some bad effects for them. Anywho, so don't worry, just know that. Anyway, so just know that caffeine is a methylxanthine. It kind of fits in the same class here. So again, a lot of the side effects you associate with caffeine, guess what? They're going to also apply here as well. So kind of keep that in mind as we go forward. Now, we don't use a lot of these anymore. You may still use these on rare occasion, but it's good to know for sort of historical perspective, and you may still find older patients with older providers who still use this stuff, okay? I'll give you a classic example in just a few minutes here. But basically, compared to a lot of the other long-acting medications like the inhaled corticosteroids and things like that, they're less effective and they're less well tolerated, but they have a very narrow therapeutic index, okay? That means you got to do what? Monitor drug levels, right? So again, very few patients get put on these, maybe more on the COPD side of things, which we'll talk about a little bit later on, but be careful with these medications here because of that therapeutic index. The big one we have is called theophylline. It's a very old drug. And again, usually you're going to find there's probably like your 80 or 90-year-old patients who probably have providers who are 80 or 90 years old who they've been on it for like 40 years, right? And it's like, well, it ain't broke, so I'm not going to fix it, right? So they leave them on this. The problem is that theophylline is renally eliminated, and guess what happens to older patients? Renal function tanks over time, and then guess what? No one ever goes in and readjusts their dose, or they never monitor levels. And so I've seen one really bad case that came in, lady who's probably like 85 years old, she's coming in from the nursing home, gets a viral illness, gets dehydrated. Guess what renal function does? All of a sudden, the theophylline levels are going to go sky high. She comes in seizing, right? Because this medication can act as just like caffeine. What does it do to your CNS? Stimulates you, right? Does the same thing with theophylline. When these levels get really high, just like caffeine, and really high doses could cause a seizure. This was causing a seizure in this patient. Unfortunately, could not stop the seizure. She had so much theophylline built up in the CNS that she unfortunately died from that. So again, be careful whenever you see someone on theophylline. Make sure you're checking those levels. Make sure you're checking renal function, okay? They can be effective, but you have to watch out for things like arrhythmias occurring. You have to watch out for these convulsions, etc.
So let's say in that case, if we were to get toxicity, is there a way other than dialysis we can reverse this, or just dialysis is the only option?
A lot of benzos to try to treat through the seizures, and dialysis is the big thing. But, again, this patient, one of the other problems you run into is you see some hypotension associated with that. So, again, this lady came in, she's profoundly hypotensive, tachycardic, having seizures. Getting a dialysis catheter in was very difficult. Even once we did get the dialysis on, you find that theophylline doesn't cross the blood-brain barrier very easily. So once it's there, it's kind of stuck. And so, unfortunately, even though we pulled it out of the bloodstream, there's still a lot in the CNS, and she ended up in this non-convulsive status epilepticus and ended up dying from that. So, yeah, it's a very sad case, but it's one of those things we got to monitor these patients, right? And a lot of patients don't get good follow-up, they don't get monitored effectively, and just one of those small, things where, hey, they didn't have good PO intake for a couple of days, and all of a sudden renal function just tanks. Anywho, but basically the way that these are going to work, the mechanism here, you're going to find that they actually are working through several different mechanisms. One of the big one is they act as an adenosine receptor antagonist. Usually adenosine kind of puts the brakes on the system in general, right? So if anyone familiar with using adenosine on the heart, we'll talk about that a little bit later when we talk about antiarrhythmics, but one of the cool things you'll see if you ever give adenosine for like supraventricular tachycardias, what happens to the heart? Stops. You're like, uh-oh. And then it comes back and you're okay. Same thing to the brain here as well. Adenosine usually kind of is going to be a depressant on the CNS. Well, if I block that, guess what happens to the CNS? It gets excited, just like when you take caffeine to wake you up so you can study for your quiz in the morning. The same thing is happening with theophylline. So you see a little bit of that, which makes sense why you end up having some of the CNS effects seen with that. But also because you're antagonizing the effects on the heart, what do you think it does to the heart? It's going to beat faster. You see tachyarrhythmias associated with that. So that's why these drugs are so dangerous due to their effects here. But the big thing is they're going to help with things like inhibiting phosphodiesterase. So you end up seeing smooth muscle relaxation in the bronchial smooth muscle. That's where you're going to see a lot of those effects there. And also it's going to have some anti-inflammatory properties. Okay. Now the only time I ever see this, and I've seen it once or twice used in pediatrics, there's an IV form called aminophylline that gets used if the patient is refractory to everything else, like very severe status asthmaticus. They've gone through every other medication. We'll put them on an IV drip of aminophylline that shows corticosteroids is not done very frequently, but can be used if they've failed everything else essentially. Okay, but just again for kind of historical context, be familiar with that drug theophylline.
So, like caffeine, you can build tolerance to it.
Mm-hmm.
Build tolerance to it.
Not from the respiratory standpoint, not necessarily, but yeah, certainly like the CNS effects. Maybe you might find, like if you're starting this in an elderly patient, you may see they may be a little bit more, say, agitated or anxious or something like that. They probably will get somewhat used to those effects over time, but the anti-asthma effects stay there pretty much. Yeah. Is that your question?
Yeah, I was just asking what the IVs used for kids again.
So IV could be used for anyone who's like really refractory to everything else. You may see it in adults or kids. I just say, because actually, it's kind of funny. Dr. Levine, when she was working over at Nemours, I remember I saw the order come over for aminophylline. I was just calling her up. I was like, "What the heck? Like, we don't use this. Like, this is the first time we've used it in this hospital. We've been open for like 3 or 4 years." She's like, "Oh yeah, it's an old school drug. I guess probably showing my age when I use this." And so I was like, okay, well, so she kind of went through the dosing she was using and all of that. So it's not done frequently, but it was a very severe case where kind of everything else was not working for that patient there, right? So anyway. So looking at the effects, again, it's going to have some mild diuretic effects, can stimulate gastric acids. That's where you can see some of the GI side effects associated with that. Again, don't memorize the levels necessarily, but just if I ever were to put, say for instance, I put on a test question and say, a patient comes in and they have a level of 30 micrograms per ml, and I would have the reference range. I would say like, say 10 to 15 or 10 to 20 or so. Which side effects would you expect to see from theophylline? Say, convulsions, or might have tachycardia or things like that. Kind of be aware of like what are the toxic effects you may see in a patient that had a too high of a level. Okay. Just so you know, it's pretty narrow therapeutic range here. Once you get anywhere above that, and notice even within the therapeutic range, you can start to see side effects. Some patients are going to be a little bit more susceptible to that than others. And then certainly once you get up in the 30 or 40 range, that's when you start to see patients tend to tank here. All right, so any questions from the first half there? We're kind of booking kind of quick for this, but I'm just so excited to get to cardiology and start getting to those meds, Anyway, so we were talking about some of the different medications we have. Some are good for control, some are good for rescue purposes when it comes to asthma. The anticholinergics can kind of fit both roles as well, as we'll see here. So typically for asthma, you're going to be sticking with the short-acting anticholinergic. And this makes sense why we can use this, because we said with the muscarinic actions, acetylcholine in the lungs, we saw the killer bees, right? We saw bronchorrhea, bronchospasm. By inhibiting that, we can reverse those effects there, right? So again, you're going to hopefully see some smooth muscle relaxation and help with that drying out of the lungs as well. It's going to decrease that mucus secretion there, right? So the main one we're going to see used in asthma is going to be called Atrovent or ipratropium. There's a long-acting one that typically lasts for about 24 hours or so throughout the day. This is going to be tiotropium or Spiriva. This one's going to be used in COPD only, though. We do not use tiotropium in asthmatic patients. Or if they do, I don't see it very commonly, right? So again, typically reserved only for COPD. So now remember the anticholinergic side effects we mentioned. The big benefit here is we don't see a lot of these systemic effects, which is nice, right? Because of the fact that we're going to be just limiting it to the lungs for the most part. Shouldn't see a lot of side effects from that standpoint. But remember the mnemonic, because again, this is a handy mnemonic to remember. Again, I can't tell you how many calls I got to the poison center. One of the things with Spiriva is it actually comes as a tiny capsule filled with powder. It has a special inhaler that you put it into. You press a button, it'll pierce that capsule, and then you inhale it. I cannot tell you how many old folks I'd have calling me up on the weekends in the poison center saying, "Oh my goodness, I swallowed my Spiriva capsule. Am I going to die?" And I say, "No, you're not going to die. Actually, it doesn't get absorbed all that well. You're going to be totally fine. But you still need to, take another dose so you can actually inhale it. But because whenever you put drugs as a little tiny capsule, people think, oh, I need to take it orally, right? So it's one of those things where they ended up seeing, some accidental poisonings, which actually clinically aren't really all that of concern. But just remember that mnemonic. It's a good one to remember, just like the dumbbells, so you can go back and kind of reference that. But the other big thing to note for management of acute exacerbations, right? So not just your typical, hey, I just need a typical rescue dose of albuterol. This is going to be for more severe exacerbations that are coming to see you because of this exacerbation. This is where oral systemic corticosteroids are going to be utilized here, okay? They're very good for suppressing and controlling that airway inflammation that's happening there, right? And typically with asthma, you kind of see this kind of biphasic sort of presentation where they'll have this sort of an acute inflammation, but then you also have kind of a later stage inflammation inflammation that occurs there, several hours later. And so the steroids here are going to be really good for helping suppress, especially that later phase of inflammation, to help control them throughout that first couple days or so after an acute exacerbation. Okay. Again, these are the most potent agents we have to help control asthma, but they have a lot of side effects when given systemically. So you do not control asthma with oral steroids, or IV steroids for that matter, for most asthmatic patients. If they're coming into the hospital to get admitted, they'll have them on it for a couple of days and then eventually try to taper them off of it. Okay. Big ones we use here. Prednisone. We talked about prednisone before, right? We talked about the liquid form called prednisolone, right? So that's going to be good, especially for little kids and stuff that need liquid. We have methylprednisolone. This is basically going to be the IV form or the parenteral form. We can either use this orally, but a lot of times if you need a IV steroid, methylprednisolone gets used pretty frequently. It's called Solumedrol if you ever see that. When you see a Medrol dose pack, that's methylprednisolone you're providing for your patient. Okay, and then we also have dexamethasone that can either be used orally or parenterally. I'm seeing a lot of patients, at least in the pediatrics, switch over to using dexamethasone. The nice benefit with that is that typically you're treating these patients for about 5 days or so with steroids, right? You use like prednisone for 5 days or so. Most of the packs are usually dosed over 5 days or so. Nice thing with dexamethasone is a lot longer half-life. So what we're actually doing nowadays for some of our patients is we're giving them a dose of dexamethasone in the ER. Because that's a long half-life, we'll tell them to take another dose 36 hours later, and then that's all they have to take. So 2 doses rather than having to take prednisone, say, for 5 days worth, right? Say every single day. So it's kind of a nice benefit with that.
Is it okay to mix Decadron with ibuprofen? We did in my pediatric clinic just because they didn't like the shots.
Mm-hmm.
I just was wondering if that's okay.
Shouldn't be a problem administering these together, because again, they're both having anti-inflammatory activity, so you shouldn't see any problems with that. You may see some GI upset, but yeah, it shouldn't be a big deal. Yeah, this way.
For steroids, do some of them have are they packaged so that it tells you how to taper them, or do you have to do that?
Yeah, so both, right?
Okay.
So again, typically you'll find that if you have something like a Medrol dose pack, you'll see something where it may, for instance, say have like a little dose pack we have. That's not very good. I need like a bigger marker. Or say you'll have like 6 doses. No, this is good. Anyway, you have basically 6 tablets. Just ignore all that. Basically, have like 6 tablets like on the first day, and then you do 5, 4, 3, 2, 1. So that's a taper built into it. But what do we know about tapering steroids? When do you need to do it? If they're on it for more than 5 days or a week or so, right? So again, it's one of those things where the Solumedrol dose pack has just been around for so long, and again, many years ago, we thought you had to taper everyone because you're worried about what were you worried about? Adrenal suppression, right? So again, you suppress the adrenal glands, you take them off the steroids, and all of a sudden, their adrenal glands have not kicked up and producing cortisol again. So because we know we don't really need to worry about that unless it's more than 5 days or so, you don't have to do a Solumedrol dose pack. However, a lot of people still prescribe that. It's just kind of what they're used to. That's totally fine. You're not going to be wrong for doing a taper, but it's not really necessary. So again, a lot of times we'll just send kids out with, say 5 days worth of prednisone or that 2 doses of the Decadron, and they're good to go from that standpoint, right? But if they're on it longer than that, they have to taper. So for instance, we admit a kid to the ICU is very severe. Again, when you have an asthma attack that is kind of unrelenting despite therapy, you call that status asthmaticus, right? It's a very severe asthma attack. And so what we'll do is we'll actually have them on steroids potentially for much longer than a week, depending on how severe their reaction is, and then we do have to taper off. So we'll build that in. We'll say maybe they're getting methylprednisolone IV every 6 hours for, say over a week. Then we'll taper them down to say maybe every 12 hours. They'll do it every day, and then we'll switch them over to oral, and we'll taper that dose down. And again, every patient's a little different. Some people need to taper longer, some shorter. It just depends. Yep, very good question there. Now again, mentioned the adrenal suppression, and you can cause growth suppression, especially in little kids. But again, that's why we don't use these all the time for these patients here. Things like hypertension. What do you think you see hypertension?
Because of
Mineralocorticoid effects, right? You're going to hold on to more fluid when you give this to these patients. You're going to hold more salt, more fluid in those cases, right? You can see things like muscle weakness, especially in the long term. You can see things like immunosuppression, which again, what could have caused that asthma exacerbation in the first place? Illness, right? So viral illness, bacterial illness, anything like that. So it could be one of those things where you can actually make them more susceptible to future infections, right? In the meantime. So again, if we can avoid using these, that's great. But if you're having a true acute asthma exacerbation where the rescue inhaler is not doing the trick, oftentimes that's to come in and get some of these steroids for a short course, usually about 5 days or so. Now again, looking at how you are going to be dosing these patients or what medications you use, it's a stepwise approach and needs to be really individualized to the patient based on their symptomatology, right? So again, some patients are going to have more symptoms during the daytime, maybe when they're more active or when they're being exposed to allergens. Some patients have more nighttime sort of symptoms or they're being woken up frequently due to the asthma attacks, and so you need to tailor it based on that. So for instance, say you're just looking at step one, maybe they're having very intermittent symptoms, maybe only around certain triggers. They can just get away with a short-acting beta agonist. Right, so that's what that SABA stands for. And say LABA, that's going to be a long-acting beta agonist. That just can be used as needed, right? So no big deal. Once you start to get more persistent symptoms, this is where you want to add on something like a controller medication. The low-dose inhaled corticosteroids is a very preferable one because it has low systemic side effects. It has very good efficacy if you use it consistently, if you give it time for it to really kick in. Alternatively, if they couldn't tolerate that or they didn't want to be on a steroid, you could have something like a leukotriene receptor antagonist, use something like theophylline. I would definitely not recommend theophylline anywhere near first-line therapy, but that is an alternative you could use. But then stepping it up, notice here, inhaled corticosteroid plus a lot, right? So now you're using two different drugs as a combo, or you could use maybe just bump up the dose of the inhaled corticosteroid. You have some options here, right? So again, depending on the patient, I probably would venture to go low-dose corticosteroid plus long-acting beta agonist, just because I've used those medications before and they're great. They're awesome. I love Advair. I wish I was getting sponsored by them, but I'm not. But they're a great drug. And then, but again, you look at your alternatives, right? So again, try to maximize their steroids, long-acting beta agonists. If those are not working, then you move on to more oral medications. A lot of times I see patients who are on, say, inhaled corticosteroid plus long-acting beta agonists and a leukotriene receptor antagonist. You see a lot of singular mixed in with some of these. So just kind of titrate, look to see how they're responding. Again, have them keep a good, accurate journal of when their symptoms are occurring, what time of day, how often, etc. And again, one of the big things you can tell how effective your treatment is being is based off of their refill history. So for instance, a lot of non-compliant asthmatic patients are going to have, they'll have many refills left over on their controller medication, but what about their short-acting beta agonist? They're running out of refills or they get refilled too soon because, again, they're not being compliant to their controller medications, so they're having to use their rescue inhaler all the time. That's a drug you can't really be non-compliant to because if you need to breathe, you need to breathe, and they're going to be very likely to use that. So if you have a patient who says, "Oh man, I ran out of refills. Oh man, albuterol. Can you give me another script?" And you'd be like, "Well, what happened to that? What happened to that Advair I gave you?" Like, no, I got plenty of left on those. Like, really? Because you shouldn't have run out already. What's going on with that? It's one of those things where you can be like, "Okay, are you really taking this stuff? Are you really being compliant?" Because you don't want to go and just start titrating up on your dose, and the patient's like, "Oh, I'm taking it all the time," when they're not, right? When they're being, or you have a suspicion they're being non-compliant. Because again, do patients ever lie to you?
Yes.
All the time, right? So again, always just assume they're lying to you until proven otherwise, right? Not because they're trying to be mean or anything, but just because they don't want to get the nasty stares or the hey, I told you to lose weight, why don't you lose, that kind of thing. Like, they don't want that judgment, right? So a lot of times you have to make sure to see if they actually are being compliant, and refill histories can be somewhat useful with that, right? And again, you can, as a provider, you can always call up the CVS, the Walgreens, wherever they fill at, and talk to them and be like, hey, are they actually filling this stuff? A lot of times they'll just say, I just want the albuterol. Don't give me the other stuff because it's expensive or whatever the case may be. So again, you can call and talk to the pharmacist there, and they'll give you all that information as long as you can, provide information, patient identifiers, etc. Right? Yes, ma'am.
What's a way around, because well, I know you said that you could increase the steroid doses if you didn't want to do a combo. Because I know the combos are more expensive, right?
It depends. A lot of those are still brand name only, and so those tend to be more expensive. But it's one of those things where a lot of insurances will tend to cover. They'll have like a preferred one that they'll cover. So, for instance, if you switch insurance, you may go from Advair maybe to Symbicort. But again, if it keeps you out of the hospital, that's usually a lot cheaper to pay for that medication than it would be to pay for the admission, right?
Yeah.
So it's one of those things where it may be more expensive, but depending on insurance coverage, maybe cheaper just to go with the fluticasone inhaled by itself, and if that's not really working, then maybe try to step it up.
Could you do like a long-acting alone and tell them to use an inhaled corticosteroid, or does it have to be?
You typically only see the long-acting beta agonists by themselves for like COPD. I don't normally ever see anyone recommend them separately like that. There may be a specific use case. I'm just not aware of it. Yeah. But you'll see, again, the steroids plus long-acting is going to be good for COPD as well, as we'll see in just a few minutes here, right? But again, as you're moving up, and notice here, this is when you can start to consider things like OMalley or Xolair. Again, that's for patients who are really refractory to everything else. You may probably want to keep them on things like their steroids, but it may be just not enough, and that's where you need something like Xolair to really kind of kick it in the butt and get that IgE bound up, right? So just something to consider. But again, a stepwise approach. So if I had a question on a test, this patient was managed, with they're going through their short-acting beta agonists like crazy. They're only on fluticasone, twice daily, but still symptoms are out of control. What's the next step in therapy, right? And I may put something like theophylline, which we know now, like I probably wouldn't jump to that. I may put like Xolair. I may put something like prednisone. And then I'll put something like, long-acting beta agonist plus fluticasone. You'd be like, okay, well, that's the next step that I would take to bump them up a little bit without going so crazy as to use theophylline or Xolair. And then obviously oral prednisone is not going to be a good option. That's only for acute exacerbations. You don't want patients on that 24/7 because of all the side effects associated with them, right? Does that kind of make sense? So kind of think about that stepwise approach there, right? Okay, now looking at your options as far as giving these medications, because technique is everything when it comes to inhaled medications here, right? So we have several different options. Now, one way you could give these medications is via nebulizer. What is a nebulizer? You don't have to answer because you already know the answer, right? You know what it is. Basically, it's a machine. What does it do? It vibrates at very high frequencies and will basically aerosolize all that medicine and will make it into this nice fine mist. That's very effective because, again, one of the nice things is once you kind of put it on the patient with your via mask or with the actual the mouthpiece is that you can even have just passive inhalation of the drug and you should still get some efficacy out of it. The other problem with that is that the dose is super, super high. So they're breathing a ton of drug. You see a lot more side effects. I remember growing up, whenever I had like an asthma exacerbation, I get a cold or something like that, I would get put on the nebulizer. My sister and brother would make fun of me because I was on this nebulizer and trying to breathe into this machine. But regardless, I was so jittery and jumpy afterwards because of all that beta-2 agonist I was breathing in, way bigger dose than I was getting with just a normal, albuterol inhaler. So because of that, you see a lot more side effects, but you do get a much bigger dose. It's good for kids too, because sometimes they're not going to be super compliant with trying to inhale that drug. So again, it can be useful in that case. But again, I mentioned the dose is a little too big. One thing you can do to get around that is using something like a spacer or a valve holding chamber. Basically, this is an attachment you put on the inhaler itself, and you would actuate the medication. It would come out and stay in this chamber, and then the patient can inhale it kind of at their leisure. The nice benefit about that is that you don't have to worry so much about the coordination between hitting the inhaler and actually breathing it in, right? Because the technique is really important there. Who might else have issues with breathing in that dose and kind of coordinating that? Older people, right? People like arthritis, like rheumatoid arthritis. If you have, any issues with that, it can be really difficult. So that's when you're using a metered dose inhaler. That's the typical kind of like, canister you're gonna be pushing through. That's a propellant in it, right? So again, you have to coordinate that very much. Other drugs may come as what we call a DPI or a dry powdered inhaler. That's basically where you will open up the medication. You will usually there's like a trigger or something that will puncture like a capsule of the drug. And it's just a dry powder at that point. And so basically the patient is providing all of the inhalation themselves. So they are I guess not really the propellant, but they're sucking in the medication on their own. So in that case, you don't have to have as much technique as far as coordinating when you actuate the medication versus breathing it in. But again, who might have issues with that? Yeah, if they have a hard time getting that good inspiration, they may not have enough kind of force to actually inhale the medication in the first place. These are all things you might kind of consider as what's a good dosage form for your patient there, okay? And in fact, one of the things you find is that when you're looking at a valve holding chamber, the dose you get is usually a lot, it's more efficient at delivering a dose. And in fact, in some cases, they may be just as good as using a nebulizer for some patients. So again, most of the time though, if you go in the ER, urgent care, they'll probably just hook you up to a nebulizer, but those can be just as effective if you use a good valve holding chamber. Anyway. Now, basically, the technique you're going to be shooting for, and this is a meter dose inhaler, right? So this is one that has the propellant in it. You're going to be taking off the cap. Obviously, you want to shake it up, right? That way, you make sure if any of the drug is maybe separated out in the mixture, you go ahead and get it nice and mixed up again, okay? Now, the first time someone uses an inhaler, if they haven't used it in a while, you may need to prime it, okay? So again, it may be something where they think they're losing drug, but it's okay. You want to make sure that when they get the dose, they get the full dose there, okay? So again, they're going to go ahead and breathe all the way out. It's going to expire. You're going to hold the inhaler kind of as shown. So again, they shouldn't hold it like out to here. Or did I show you that GIF where the lady was shooting on her neck? Right, that doesn't work. Right, it needs to be mouth on the inhaler there. And so basically you're going to start to breathe in. You kind of want to get the airflow kind of already going, right? So you want to make sure that when the drug comes out, it has a nice kind of airflow to get into and kind of get sucked down into the lungs. Kind of like, you guys ever watched like Finding Nemo? Hopefully you guys aren't too young for Finding Nemo. Remember the turtles when they had the nice slipstream that they were going in? That's kind of what you want to make as far as the airway goes, right? Again, you have to think about ways to explain this to patients. But start to breathe in. You'll press down on the canister itself, and then that way the patient can then get a nice big breath in. You want to hold it for at least 5 seconds. They can hold it for a little bit longer. 10 seconds is really good as well, and then they can breathe it out. Now, typically, what's the dose on an albuterol inhaler? 2 puffs, right? So, you want to just do 2 puffs all at once? No, you want to separate them out. Why do you want to do that? And breathe it in, give the first dose time to work, kind of start to loosen up those bronchial muscles, and then the second dose can do what? Goes even further in, right? So you can get even deeper and really kind of work even better. So I usually like to tell them wait 2 or 3 minutes in between doses, so that way you kind of have good, opportunity for the first dose to kick in, and then the second one can be even more effective the second time. Okay, that's what I usually recommend waiting for. Now again, this is a chronic illness. It's not something some people will grow out of it. Some people may be moving environments, and that can help out quite a bit there. But just know, what's going to be your long-term medications. Know they need to be used consistently to work, and then know the delineation between those and then your short-acting medications. So if I have a test question comes up and it says which one of these are going to be good for an acute asthma exacerbation, what are the options? Albuterol, levoalbuterol, ipratropium, right? Or if I said maybe for an acute asthma exacerbation, patients coming into the ER, what else could I use? Steroids, right? So again, if they happen to come in to see a healthcare provider, they could use a systemic steroid, oral, IV, whatever, right? So again,
not talking about like anaphylaxis.
Not anaphylaxis, right? No, not like full-on anaphylaxis, but yeah, you typically do not need to give epi to asthmatic patients. Very rarely have I ever seen that. Yeah. And in fact, if you have a case where you actually have to intubate a patient with status asthmaticus, there's actually a certain sedative we can actually use on those patients. There's one called ketamine that we'll use for them that actually has some beta-2 agonism kind of built into it, because it actually helps to kind of release natural catecholamines like epinephrine and norepi, and that kind of activates the beta-2 receptors. So if you ever see an asthmatic kid get putting on ketamine, that's usually what we're using it for, is to try to bronchodilate in addition to sedating them so they can be compliant with the ventilator.
How about IV magnesium if it doesn't resolve? Can we get that for asthma?
Yes, that is another very good option. I'm trying to think, do I have anything on status asthmaticus? I do not. It's a very good point, though. So the other thing you may see occasionally for more severe acute exacerbations is going to be IV magnesium. Anyone know why we use IV magnesium? Yeah. Yeah, so it acts as a smooth muscle relaxer. So we'll talk about calcium channel blockers a little bit later when we get to the cardiology section. But basically, for smooth muscle to contract, you need what ion? You need calcium, right? So again, if I have magnesium, it can kind of help to blunt that increase in calcium influx, and so it can act as a smooth muscle relaxer. So you will use IV magnesium. Sometimes we'll put on a drip for that, and that's more for those really severe cases, right? So they're getting admitted, they're going to the ICU potentially. We'll use that for them. Yep, very good point. Thank you for mentioning that. Also, in addition to that, it causes smooth muscle relaxation in the lungs. Where else could it cause smooth muscle relaxation? In the blood vessels, right? So again, hypotension can be a big side effect you see with that. So you want to make sure you give them lots of fluid to make sure you kind of tank them up and get ready for that. We'll talk more about that when we get to the calcium channel blockers in a minute. Now, COPD, basically, you're going to find that a lot of the same medications are being used here. They're just used a little bit different. But again, with COPD, usually the most common cause is smoking, right? So smoking causing kind of chronic damage to the lungs. Typically, you're going to find that they will be asymptomatic for a long period of time because you typically have some residual lung function that can kind of pick up the slack. But as you go down in lung function, you're going to start to see the severity of symptoms are going to increase pretty progressively, right? So again, you'd like to be able to preserve as much lung function as you can, but none of the drugs we have here are actually going to be able to preserve that function, right? The best thing you can do is try to reverse their habits, if that's what's playing a role here. And again, smoking probably being the most common. We'll talk a little bit about smoking cessation here, but this is a good graph because it kind of shows you what you should be focusing on as far as medications go. And again, smoking cessation is the biggest one, which we'll talk about in a moment. You want to make sure that they are getting their annual flu, getting their pneumococcal vaccine when appropriate, because COPD probably does what to your immune system in the lungs? It makes it harder to fight that off. Also, all that hot gas they're inhaling over years and years, what do you think it does to all that ciliated epithelium in the airway? Gets rid of it, right? So again, you see that. That's why you can see things like cancer develop there, because you're chronically damaging those cells, and so they're going to cause dysplasia occurring there. So you can't get rid of all those bacteria and things normally. So you want to make sure you're going to go ahead and vaccinate them appropriately. Now, as far as the therapy goes from the inhaled medications we talked about, you do want to use short-acting bronchodilators for acute exacerbation. So albuterol is going to be totally appropriate here. But then you want to start thinking about some of the long-acting inhaled bronchodilators. So this is where you can see something like tiotropium or Spiriva is going to be playing a role. So you can use a long-acting anticholinergic. It's going to be good for these patients. You can also start to use things like, long-acting beta agonist. Right? So you can start to see, that's where you might see like salmeterol used by itself for a COPD patient. That's okay in COPD. It's not okay in asthma to use a long-acting beta agonist by itself. And then you can start to consider combinations of drugs, right? So you may see them on Spiriva and salmeterol by itself. You still will see them use inhaled corticosteroids as well. So you're kind of trying to use everything in your options you can to try to help control these symptoms there. Then you have to consider things like theophylline being added on. COPD patients, you still may see this being used a little bit more frequently for those patients, but it just depends on their provider and how comfortable they are with using it.
So anticholinergic is preferred over albuterol in COPD patients?
Just for the long-acting sort of medications, like for an acute exacerbation, I would still use albuterol first. But for as far as controller medications go, tiotropium might be a good first option for them as far as controller stuff goes. Yeah, for sure. And again, what's the ultimate therapy for COPD?
Smoking.
Lung transplant ultimately, right? So you go transplant the lungs. But yeah. So things like oxygen, you're going to be thinking about, stop smoking, all that good stuff. But these are at least the medications you're going to use. Still a stepwise approach. So again, if I had a COPD patient and I said, they're using their beta agonist, their albuterol too frequently, what's a good first line medication you can put them on for control? Spiriva might be a good option, right? Tiotropium would be a good option. Long-acting beta agonist would be fine. In any of those cases. Okay. All right. So as far as smoking cessation goes, what can we use to help the smoking cessation? Okay, we'll talk about Chantix in a minute. What's the other thing you can do? What are they addicted to? Nicotine, right? So they're addicted to nicotine. So how can you get someone off of nicotine if they're addicted to it? Give them more nicotine, right? So titrate them off of it slowly, right? So again, this is one of the things we're going to find. We can either give them something to replace their addiction, slowly titrate them off of it, or we can give them other medications that are going to help to blunt those cravings they're going to see there. So those are the main two things we're going to be looking at that. And again, this is where combination therapy is going to be great because you want them to have some sort of nicotine replacement in addition to other sorts of things like cognitive behavioral therapy or something else. Because again, how frequently do people kick the smoking habit? All the time. Super easy. I don't know. I just tell people stop smoking, and they're like, okay, great, I'll do that. No, they don't. It's very hard to kick that habit. It's very difficult. So because of that, they need to use combination therapies of both farm and non-farm therapies options.
Now, there's some controversy with the electronic cigarettes.
Mm-hmm.
I know that you're getting the nicotine and it's not as many chemicals, but I heard that it could be just as bad as regular cigarettes.
From what standpoint?
From being bad for you.
From being bad for you. Very scientific. Yeah. So the thing with vaping is that you have to look at, for instance, what they're actually inhaling, right? So again, as far as the regulations on that stuff goes, it is kind of the Wild West, right? So it's not when you go to a vape shop, you go to Open Smoke or whatever their punny name is going to be for their smoke shop. You're going to find that they don't have a lot of regulations on that stuff. They're not considered drug products. So you can put whatever you want in that stuff. You can put all kinds of flavorings and all kinds of other stuff, and you have no idea what's actually in it, right? So because of that, who knows, right? Maybe decades down the road, we're going to see that, this one additive they put into a lot of these products causes cancer, right? But smoking also, we definitely know causes cancer, right? That's kind of a known quantity. So the other big benefit with using electronic cigarettes or vaping, things like that, is that typically the gas they're inhaling is a lot lower temperature than what you see with the actual smoking, right? Because again, you're lighting something on fire and breathing that in. So that hot gas is very damaging in addition to all the other stuff you're pyrolyzing and burning off that you're inhaling, right? So there's kind of two components there, and that long-term kind of heat damage is what causes a lot of the dysplasia and can lead to a lot of that potential cancer forming, things like that. So overall, who can say what they'll say 20 years down the road? But if it's something that is a road to them getting off of nicotine completely, fantastic, right? But again, if they're just breathing in nicotine, maybe some of the other kind of other products that are in there, who can say, right? So it's probably better than smoking, but we just don't know yet, right? And maybe it's one of those things where the government will come down and regulate it one day. Who can say? I mean, we still don't even have child-proof or child-resistant containers on a lot of those, and that's so much nicotine that if a kid even gets one mouthful of that stuff, it can be potentially deadly. So again, there's a lot of stuff we would like to see different from a regulatory standpoint.
Yeah, just one thing. the electronic cigarettes, they actually are going to start regulating them. I
Okay.
think by 2020, just because I was involved in some of this
Okay.
studies. But they keep pushing it back. That's the problem. It's supposed to be like 2018 or something like that.
Mm.
And you just see a lot of these like Philip Morris, Logic, all of those guys are doing that. So.
Yeah, so like I said, who can say how the landscape will change? You know, yes, I think more regulation on that kind of stuff would probably be good, I would think. I mean, I'm not usually like a big, like, let's regulate everything, but I'm just like, who knows? At least the child-proof stuff, at least from a toxicology standpoint, like that's, I think, it like has to be done. Like that would be really good if we can get some child-resistant containers on it, because again, they still have really concentrated nicotine, and that stuff even gets absorbed through the skin. So if you were to spill it and get it on a kid or something like that, they can be really susceptible to it, right? But anyway, but yes, that could be one agent, because again, that's nicotine replacement in these cases, right? Also, they can taste like cotton candy, so there you go. It's, anyway, so the agents we have here, so we're going to talk about bupropion. We're going to talk about some of the nicotine replacement agents here. Now, there's lots of different options. We have things like patches we can use. We have things like the gum. You have sprays. You have like a nasal spray, and you also have like an actual inhaler that's kind of like a cigarette. Now, again, you have to think about the component of the psychological component, not just the chemical dependency. Again, having that motion, that physicality to it is another big component. They kind of need that. So sometimes you have to kind of tailor it to what's kind of best for the patient from that standpoint. I swear I had this one teacher, he must have been like 8,000 years old. He's my Chem 1 professor. His name was Dr. Healy. I presumed that helium was named after him, if I had to guess. But he had this resting tremor he had, but you could tell like the way he held the chalk in his hand, it looked just like a cigarette. And I was just like, oh, this dude's been smoking for like 900 years. Like, but anyway, but there's a certain physicality to it that is can be part of the psychological component, right? So sometimes the nicotine replacements can be very good from that standpoint. They can kind of replace that, and that's why the e-cigarettes can be good too, because they still get that they get the feeling of like, yeah, I'm smoking, but it's something that may ultimately be worse for them, or maybe probably better if I had to guess, but maybe not as bad, but still bad, right? So who can say, right? But the last thing we'll talk about is going to be Chantix as well. All right, so bupropion. Basically, this is going to be a drug we're going to talk more about when we get to the psych meds, right? We're going to talk about this in terms of treatment for depression. A lot of the depression meds are going to be working on the reuptake of serotonin, okay? Serotonin, you think of being the kind of feel-good, happy chemical. This is actually going to be working more through dopamine. Now, again, why do people get addicted to things? That's a dopamine, right? I talk about the dopamine squirts, right? So if you have a big juicy hamburger, if you have sex, if you smoke a cigarette, all these things are trying to triggering off that mesolimbic system and triggering those dopamine releases, and that says to your brain, this feels good, I want more of this, let's keep having it, right? So whether it be heroin, cocaine, whatever you want, certain people are going to be susceptible to this, right? So this is what this is doing, is trying to disrupt that system and trying to regulate how your brain's going to be handling dopamine. It's basically blocking reuptake of dopamine from the presynaptic neuron. Okay, so by blocking reuptake, more of it stays within the synapse, and it can help to kind of disrupt that system there. Okay, so even though you're still smoking, you may not still get the same sort of, or this helps to deal with more of the cravings, I should say, right? Because again, if you go from smoking all the time, getting those nice dopamine squirts, and you stop smoking, you lose that dopamine. You're like, okay, well, I feel bad now. I want that craving. I have that craving to get more. This can help to regulate that. Now, have you seen bupropion being used for anything else recently? There's actually been another drug this was used for, actually for weight loss. So you may actually see this in combination with another drug called naltrexone. Actually, has been used for weight loss. Same thing, right? Because again, food addiction is a very similar chemical process as heroin addiction, as sex addiction, as anything, right? So because of that, you can sometimes see this used for overeating disorders to help kind of regulate that dopamine. So this is one way to do it. Now, a big question to think of is, can you smoke while still being on this medication? Now, we're going to see that with the nicotine replacements, you don't want to do that. Why is that? Because you're already getting more nicotine anyway. So again, you're going to see more toxicity associated with that. It's no good. Now, with bupropion, could you still potentially smoke along with this? Yes, because we're not giving any more nicotine. So even if they fall off the wagon and they go back to smoking, you're going to find, or the tobacco, chew, whatever they prefer, you're going to find that it's not really going to cause a lot of toxicity from this standpoint. So that can be one benefit here, okay? Be careful, though, of this drug in patients with seizure disorders, because it can exacerbate that. If they are taking monoamine oxidase inhibitors for depression, because, again, that helps to metabolize dopamine as well, you see toxicity. Be careful if they're on other medications that are affecting potentially the dopaminergic system, so like tricyclic antidepressants, venlafaxine. We'll talk more about that in the psych meds later on, but just kind of keep that in the back of your mind. Because this is a depression med, you gotta be careful mixing with other antidepressants potentially, okay? Yeah, so that's usually a black box warning you're going to find on most antidepressant medications. Probably not as big of a deal for someone who does not already have depression, I would say. Oftentimes what you find is a lot of depressed patients may have suicidal ideations, but they also have no energy to actually act on it. Okay, so it's one of those things where it's like, well, I would kill myself, but I just don't feel like getting up, right? I mean, not to make light of it, but that's kind of the mindset. So what you see is that usually when you start someone on one of these antidepressants, it kind of gives them more energy initially without actually fixing their depression symptoms. It usually takes like 6 weeks before you really see the full, sort of mood altering sort of effects there. So all of a sudden they get this kind of bump in energy, like, oh, well, now I can act on these thoughts that I've been having, and that's when you can see that increased suicidality. That's kind of the way I think about it. But yeah, a lot of them carry a black box warning for that, but I would be more worried about in someone who had history of depression than I would for someone who's just had a smoking addiction by itself. Right. But again, a lot of times people who are depressed also do what? They tend to smoke, right? So again, it's something to definitely consider and kind of get a full history when you're doing that. Anyway, so when you have nicotine replacements, these are meant to help replace the nicotine. They're not going to be ingesting, either inhaling or with the buccal absorption if they're doing chew or whatever like that. This helps to minimize a lot of those cravings, minimize the withdrawal symptoms. Because again, anytime you're addicted to something, if you take that away, typically the body's used to that effect around. It's going to have withdrawal symptoms, right? In this case, it could be irritability, restlessness, rebound depression, things like that. So the dose has to be dependent on how much the patient was smoking. So someone who smoked 2 packs a day is going to get a lot bigger nicotine replacement than someone who only did a half pack a day. So it has to be titrated to those effects. And again, you do not want them to smoke on top of this, because the fact is going to be even more nicotine, and then you're just kind of compounding the problem, right? Then all of a sudden they're like, oh, I got to smoke even more to get those same nicotine fix as I was when I was on the patch, right? So anyway, be careful though, patients with cardiovascular problems, you can see risk for hypertension, tachyarrhythmias, because nicotine is a stimulant, so I do want to be careful of those patients there, okay? And again, a lot of the patches, the gums are available over the counter, so again, you have easy access to those for most patients. But again, the idea is to taper off slowly over several weeks to months, and eventually they hopefully just go ahead and just get off of it completely, and then they hopefully should have no more addiction. However, it may not be the case. A lot of failure rates seen with this. Okay? Last drug we have here is going to be varenicline or Chantix. This one's actually kind of interesting because instead of working on the dopamine pathway, this is actually a partial nicotine receptor agonist. So instead of a full agonist like you would see with smoking, or nicotine from smoking, you're going to find it's only a partial agonist. So it kind of just sits there and tickles the receptor, so to speak. Less activation than nicotine itself. So typically what you do is you want to start the medication a week before the quit date. They can continue smoking, it's fine, because the reason is that this drug is going to be binding up those receptors, and it binds more tight than the nicotine from the smoking can. So you're going to find that you really don't see a big increase in nicotine effect because this is only a partial agonist. Okay, so you can continue smoking, and you're taking this for a week, so that way you kind of get used to it, and then you continue on for about 12 weeks or so. Okay. And again, pretty effective as far as these therapies go, just as well as any dopamine, bupropion would do. But the big things to note here. You can see a lot of sleep disturbances. Patients have very vivid dreams that they report whenever they're on Chantix. Very vivid, very strange dreams. They're going to be reporting about it. Just know that some people like that. Some people really, really hate it. It just depends on what kind of dreams you're having. And then the black box warning you have to watch out for is there is some risk for worsening depression and suicidal ideations. You want to be careful with that as well. Okay. All right. As I mentioned, immunizations, annual influenza is really important here, and then also make sure they get the pneumococcal vaccine as well.
Can you give anti-abuse or that's for alcohol?
Yeah, anti-abuse would be for alcohol, and again, that's the disulfiram reaction you'd be seeing with that. So we don't have anything like that for nicotine necessarily. Most times either just replacement or trying to fix kind of the dopaminergic pathway sort of thing. Yeah. Okay. So any questions on that? All right. All right, so now we need to move into the cardiovascular pharmacology. You're going to find this, we're going to cover a wide range of topics here. The nice thing with a lot of these medications is that a lot of them pull double, triple, quadruple duty, which means that you can use a beta blocker not just for hypertension. You can also use it for angina. You can also use it for heart failure. You can also use it for acute coronary syndromes. So you're going to see the same drugs pop up again and again. So it's good to have a good understanding of how these are working now as we get into them and talk about their side effects, contraindications, mechanisms, etc. Okay. First off, a little bit of antibiotics, because I know you guys missed that, and so I said, let's talk about some antibiotics. Anyway, the really only cardiology-related infectious disease we'll talk about here is going to be endocarditis. What is endocarditis? Yeah, the actual valve itself gets infected, and usually these can be pretty easy to treat, difficult to treat. These are very difficult to treat because the bacteria likes to form this nice little vegetation that sits around the valve. It can be very difficult for antibiotics to actually penetrate into that. Okay. Now, one of the things to note is that the patients who are most likely to run into this are those that have had maybe a prosthetic valve put in, because again, foreign material tends to accumulate bacteria on it. If you have like a mechanical valve replacement, they tend to be likely to get it. People who are injecting themselves with all kinds of things, because again, injection drug users, do you think they are the cleanest people when it comes to using aseptic technique and injecting medication? Some of them maybe. A lot of them probably are not, right? So again, they're sharing needles, things like that. They may not be cleaning the site well. They can be injecting all sorts of stuff into them. So we're going to find that these are the patients who are a big risk for developing endocarditis. Now, again, as I mentioned, that thrombus is going to form on the actual abnormal endothelial surface, whether it be the valve that's mechanical or the natural one. And then basically you'll have a secondary infection that will develop within that, usually from something that's spreading around in the bloodstream. That's why you want to worry about in patients who have, say, like a valve replacement, whenever they have, like, say, dental procedures done. Anything like that that can spread bacteria into the bloodstream can eventually accumulate on that valve, because, again, all blood's going to go through the heart eventually, right? And then the bacteria will then proliferate and then form that nice vegetation on there that can be very difficult to penetrate. So what do you notice about the common bacteria here? A lot of, just broadly, a lot of gram-positives, right? So you have a lot of gram-positives here. You have these Haystack organisms, which are going to be gram-negatives. But for the most part, you see a lot of gram-positives. And that is going to be important because our empiric therapy is typically going to be geared towards that. So what's our empiric therapy going to be, do you think? What's a great gram-positive IV agent? Even better than that. Because, again, what do you notice? It's actually going to be vancomycin, because in Staph aureus is 31%. Well, what if that Staph aureus is MRSA? Vancomycin is the go-to, right? So you're going to find vancomycin gets used very, very commonly. But typically, oh yes, sir.
So even for prophylaxis, will be there?
Not for prophylaxis, yeah, because again, when you're just trying to prevent an infection from occurring, that's going to be a lot different than actual treatment, right? So this is talking about empiric treatment. Yes, we'll talk about amoxicillin a little bit later and from the dental standpoint. But so this is a native valve endocarditis, right? So again, just the natural valve, not the replacement one. Typically, what you're going to do is start with empiric therapy, and then you're going to tailor your therapy based on culture results. And again, when is it important to get cultures? Before the antibiotics. And again, where are we getting the cultures from? Two different sites. Again, these are bloodstream cultures we're going to be getting, right? So again, we're not actually getting any bugs off of the valve itself. That'd be very invasive. We're just using from the bloodstream because we're presuming that this bacteria should be somewhat in circulation and we can culture out. Now again, empiric therapy should be focusing on those big gram-positives like staph, streptococci, enterococcus, and so we're going to be using especially bactericidal drugs because we would like to make sure we kill those bugs off as best we can. And so this is why vancomycin is a really good choice, right? Vancomycin, how does that work? The cell wall inhibitor, right? So again, it's going to be inhibiting that cell wall, so we know that's bactericidal, right? We know it's going to be good to kill a lot of those gram-positive bugs there, especially MRSA. That's the biggest thing in coverage. And again, look at the treatment time. You know, normal treatment for a lot of infectious diseases is 7 days, 10 days, 14 days. This is up to 6 weeks in some cases, right? So you need a lot of coverage, a lot of penetration with that antibiotic to make sure you really get all of those bacteria, because that vegetation can be very difficult to penetrate through, okay? So looking at when you actually get the culture results back, how can you streamline therapy? Well, and again, you have things like, viridin streptococci, Streptococcus bovis. They tend to be very highly penicillin resistant. And these are those cases where you'd start with Vanco and then maybe scale back to something like IV penicillin G. Again, you don't use a lot of IV penicillin G, but this is one of the kind of very clear-cut cases for it. And in fact, this is one of those things where we may actually give a continuous IV infusion of it over 24-hour periods, again, continuously for several weeks in order to make sure you're treating that, getting that good MIC, getting above the MIC consistently to kill off that bacteria. Very good from that standpoint. Alternatives you could use, things like ceftriaxone will still be good against this. Vancomycin could be used if they really couldn't receive any beta-lactams. And then the other kind of notable thing here is that you can actually use gentamicin. Now, gentamicin, we said, what kind of coverage does gentamicin have? Gram-negative, only gram-negative, right? This is a case where you can actually use this for gram-positive synergy. So by adding this on, you can actually get better kill of those bacteria, and actually what you can do is shorten up your treatment duration. See here, 2 versus 4 weeks when you add on gentamicin, right? So it's nice from a patient standpoint and also good from a hospital standpoint because you don't want them in the hospital longer than they have to be, right? So that's a very good thing. However, who do you have to be careful with using Vanco and gentamicin in? Nephro patients. Patients are going to have a hard time getting clearing that because they're going to have ototoxicity and further nephrotoxicity. Okay. Other things, again, follow your cultures. You know, a lot of other streptococcal species tend to be penicillin resistant. You know, you have things like, you know, enterococci that are going to be growing here. Those tend to be penicillin resistant. However, again, this is where you can use that gram-positive synergy with gentamicin plus something like ampicillin, vancomycin, and those are going to be totally fine there. When it comes down to Staph aureus, if you have MSSA, this is a case where you can use one of the anti-staphylococcal penicillins. So dicloxacillin, oxacillin are totally fine. MRSA, though, you got to stick with Vanco. They couldn't get Vanco, what could they use instead? Linezolid would be a good option. If they couldn't use linezolid, what could they use? I don't know if we talked about this one or not. There's another one called daptomycin you could also potentially use as well. I didn't really talk about it because you don't use it too frequently, but my wife was working last weekend, had a patient with endocarditis who could not receive vancomycin, so they switched him over to daptomycin. So that was actually another good gram-positive killer, but don't worry too much about that for our purposes here. Anyway, if you were to grow out one of these Haystack organisms, you're going to find this is about 10% of cases here in these non-IV drug abusers. They tend to be more resistant to ampicillin because of the fact they're producing more beta-lactamases. So you can see here, just by broadening out your guns a little bit, Rocephin, ampicillin sulbactam, so putting in a beta-lactamase inhibitor is good there, or Cipro can all be used for those organisms. But again, you're going to be doing it based off the cultures as they come back. So I may put it on a patient. I could either have a test question where I say, hey, you're starting empiric therapy for a patient with native valve endocarditis. What do you want to use? Obviously, you'd say probably Vanco. All right, so empiric therapy for a native valve, I'd probably just say go Vanco, right? However, I say, hey, you're growing back this bug. I says MSSA. What would you want to use? Nafcillin, dicloxacillin, any of those would be totally fine, right? So kind of think about, based on the culture results, if I put that on a test question, what would I use in those cases, right? Now, looking at IV drug abusers. This is actually a picture from my Snapchat last weekend. Just kidding. All right. Just kidding. Anyway, I don't have a Snapchat. Yeah. I had no idea how to use it. I tried one time and I was like, this is terrible. I don't like it. Anyway, so looking at IV drug abusers, why they tend to be a big risk is not only the fact their aseptic technique is probably not great, but also they could have things like if they're crushing up tablets and injecting those, they can have particulate matter. All of that can stick on the valve and can be a potential source for the bacteria to grow on. Things like skin flora, if they're using saliva, potentially any of these things can all lead to injection of pretty nasty bugs here. So you see a lot of Staph aureus here. So again, Vanco at the bare minimum needs to be used for these patients. But then also you have to consider things like fungi growing on there. Are they going to have gram negatives? And again, that's going to be told when you have the cultures come back in those cases. But think about it. Do funguses grow in a typical bacterial culture? No, you have to order for that, right? So it's one of those things where you could be treating a patient, they're just not getting any better, the white count's still up, they're still febrile, they're just not improving. They have to think, okay, well, I know they're an IV drug abuser, let's look at a fungal culture. The problem is fungal cultures take a long time to come back because they're not as easy to grow as bacteria, so you may have to start them on empiric antifungal therapy in the meantime. So just something to kind of think about. Now, if you have a prosthetic valve, so we're putting in a foreign valve into the patient here, very frequently antibiotics are not going to be sufficient for this. In some cases, you have to go back in and actually replace the valve itself. And this is why it's good to have good prophylaxis, as we're going to look at in just a few moments here. Okay. Typically, you're going to use a similar drug regimen, but actually if you have a staphylococcal species growing here, we actually use a 3-drug regimen here. So now we're introducing a new drug. So we have gentamicin, we have our beta-lactam antibiotic, plus we're using a new one called rifampin. Okay, so we'll talk about this in a second. But very frequently, if it's MRSA, it does require surgery. So rifampin is an interesting drug. It actually works on RNA polymerase to eventually kill off the bacteria. But if you notice here, what color is it? It's red, yeah. So it's actually a bright red medication. If you ever see a red medication, it's usually one or two things it's actually going to be, but rifampin could be one of them. Very frequently, it gets used for tuberculosis. So it could be a drug you're going to see used with that with some regularity. Just note that it is usually going to be added on as the final medication of that 3-drug regimen. The reason for that is because resistance develops to it very quickly. So by adding on as the last drug, you tend to retain that activity for longer, which is good. Okay. Other things you're going to see with this, you can see certainly red or orange discoloration of all the body fluids. So the urine's going to come out orange, sweat may be discolored, all of that's going to be discolored. It's good to warn patients about. And again, that could be things like sweat could actually stain clothing and whatnot. So just something to warn the patients about. Other than that, pretty well tolerated. But one other notable thing here, this is the first instance of a CYP3A4 inducer. So rifampin is a CYP3A4 inducer, which means that if it affects a drug that's a substrate for CYP3A4, levels will go down to those drugs because we have more enzyme available to interact with it. Okay, so very notable thing to note with rifampin there. Okay. Moving into endocarditis prophylaxis, that's where I'm going to be done in just 1 minute. With prophylaxis, again, these are going to be for high-risk patients who you want to prevent a vegetation from occurring in the first place, right? So again, I do not want to have to crack open a patient to put a new valve in, so this is why I'm going to prophylax for those patients. So if they have a prosthetic valve, they have a history of endocarditis, congenital heart disease, valvulopathy, and a transplant heart, anything like that, these are patients you're going to prophylax against, okay? And again, typically, there's going to be things like any kind of like respiratory tract manipulation. So if they had, like I say, a tonsillectomy, bronchoscopy, any kind of your, cutting through the skin, dental work. It's not like a routine cleaning, but if you're doing anything kind of more invasive, this is something you want to go ahead and prophylax for. And this is where we're going to use amoxicillin. Basically, by giving amoxicillin 30 to 60 minutes before the procedure, you'll kind of get good blood levels, and it will kind of kill off any bacteria that may get introduced. Okay, this is just like what we do for surgery when we're giving antibiotics before surgery. It's to try to get the blood levels up, so that way any bacteria that get introduced get killed off immediately. Okay. Again, if you had a penicillin allergy, Keflex is going to be fine here. Clindamycin, azithromycin, anything to get those gram positives. Okay. All right. So any questions? There's a whirlwind tour here. Thank you. I'm going to look at the stats on the quiz. If there's any givebacks, I will put an announcement on that. I'll take a look at the high misses and just see if there's anything that's pretty obvious. I'll try to be fair with that stuff. If you have any questions, let me know. Otherwise, I will see you guys next time. Thank you.